Hello, my name is Jumana Dawood and I'm a Year 2 medical student at MBRU. In this video, we'll review how to assess the position of an endotracheal tube on a chest x-ray. We'll focus on key anatomical landmarks, what defines correct placement, and common pitfalls to watch for. So a chest x-ray is routinely obtained after endotracheal tube placement to confirm correct positioning. Proper placement is critical to ensure effective ventilation and to avoid complications such as main bronchus intubation or inadequate oxygenation, which we'll cover later in this video. To assess endotracheal tube position, you must first identify the relevant anatomy. The most important structures are the trachea, the carina, and the right and left main bronchi. On a chest x-ray, the trachea typically lies slightly to the right of the midline. The carina is the point where the trachea divides into the right and left main bronchi. This is the most important landmark for judging the tube depth. In adults, the ideal position of the endotracheal tube tip is approximately 5 to 7 centimeters above the carina, with the neck in a neutral position. The 5 centimeter distance is typically hard to measure, so the equivalent of space between two ribs is more practical. This distance of at least 5 centimeters provides a safety margin to prevent the tube from entering a main bronchus or migrating too high. Now, neck position significantly affects tube depth. Neck flexion pushes the tube further down towards the carina, while neck extension pulls the tube upward. This is why clinical correlation and patient positioning matters when interpreting tube position. So if the carina is not clearly visible, vertebral bodies or rib landmarks can be used as an approximate guide. As in this image, the carina is located approximately at the 6th thoracic vertebral body. However, these landmarks are less reliable, especially in patients with poor image quality or anatomical distortion. Tracheostomy tubes differ from oral endotracheal tubes because they are fixed at the skin. Their tip is usually positioned 6 centimeters above the carina, roughly midway between the skin entry point and the carina, and they are less affected by neck movement. One of the key complications to consider is if the tube is inserted too deeply. The tube may enter the right main bronchus, which is more vertical. This can result in ventilation of the right lung and collapse of the left lung. In contrast, if the endotracheal tube is positioned too high, the tip may lie close to the vocal cords. This significantly increases the risk of accidental extubation, damage to the vocal cords, or aspiration, particularly with patient movement or coughing. Ventilation may also be inadequate, and an air leak around the cuff can occur, reducing effective oxygen delivery. For these reasons, a tube positioned too high is just as clinically important to recognize as one that is too low. So to summarize, always confirm that the tube is within the trachea, positioned about 5 to 7 centimeters above the carina. Assess anatomy carefully, consider neck position, and always correlate radiographic findings with the clinical picture. So that's all for today. I hope you guys enjoyed this video.